Thank you so much, Dr. Khanna. I think it's incredibly humbling for me to follow Dr. Kirtane. He and his family have had a profound impact on me growing up. So it's a real honor to be here today. Thank you so much for inviting me. And I think I'm going to do my best to cover a very hot and very relevant topic over the next 15 minutes, and one that is impacting us all across the world. So learning the hard way, thrombotic complications in COVID-19. Okay. So over the next 15 minutes, I'm going to go over a few details: the pathogenesis behind thrombotic complications in COVID-19, laboratory derangements that we see in this phenomenon, thrombosis, autopsy reports that corroborate this observation, and then the role of anticoagulation. So starting first with pathogenesis, essentially any infection, be it with virus, bacterial agents, or fungal, lead to a complex systemic inflammatory response, which is a part of our innate immunity. And our host defense systems lead to an activation of coagulation and thrombin generation, which are really critical communication components of our humoral and cellular amplification pathways. And this tie between our immunity and activation of coagulation and thrombin generation is essentially labeled thromboinflammation or immunothrombosis. As a reference point, this has been well described in other infectious etiologies, namely in ICU patients where we see increased incidence of thrombosis, particularly in the PROTECT study published in the New England Journal now almost a decade ago. We saw an evidence of 8 to 10% in the incidence of thromboembolic phenomenon despite the use of thromboprophylaxis with heparin and dalteparin. This is a really nice central illustration from a JACC state-of-the-art paper written by Dr. Bigdelli and colleagues that summarizes postulated mechanisms of coagulopathy and pathogenesis of thrombosis in COVID-19. We've talked a little bit about the risk factors. Obviously, many of these patients are acutely ill, they're bedridden, there's stasis that leads to possible thrombosis. And then of course they, as you heard from Dr. Kirtane, have a variety of other comorbid conditions. And they're also often hypoxic, which leads to thrombosis as well. With that comes this inflammatory response that we just spoke about, endothelial dysfunction, and potential superimposed infections. What we see on laboratory markers, and I'm going to speak about that shortly, is lymphopenia, inflammatory cytokine elevations, and then that leads to hemostatic abnormalities, pulmonary microthrombi, intravascular coagulopathy, and you heard a little bit about myocardial injury from Dr. Kirtane, as well as, in particular, elevated D-dimer levels and fibrin degradation products and prolonged prothrombin times, as well as potential derangements in platelet counts. What do we see clinically? Well, potentially increased incidence of venous thromboembolism and potentially arterial thrombosis as well, and a variety of cardiac manifestations that you've heard about. So let's talk a little bit about those laboratory derangements. So these really came from early observations, namely from Wuhan, China. You've heard some of these studies mentioned already, but this first study of 99 hospitalized patients noted 6% had prolonged activated partial thromboplastin time, 5% had increased or prolonged prothrombin times, but notably over a third of patients had elevated D-dimer levels and increased biomarkers of inflammation, including interleukin 6 or IL-6, erythrocyte sedimentation rate or ESR, and C-reactive protein. And there was a variation in terms of what was reported for thrombocytopenia. It was 12% in this cohort, but many of these patients had co-infections as well as septic shock. In a subsequent paper, also from Wuhan, of almost 200 patients, the increased D-dimer, specifically over 1 microgram per milliliter, was associated with an 18-fold increased risk of in-hospital mortality. And you can see here on the right where you have a comparison of increased D-dimer levels among non-survivors compared to survivors. Yet another report of close to 200 patients, again from China, where the overall mortality was approximately 12%. Non-survivors had higher D-dimer levels, and levels of fibrin degradation products, longer PT and APTT compared to survivors. And importantly, 71% of these patients had these derangements as compared to 0.6% in those patients who survived, notably DIC. So that begs the question, is this coagulopathic array of laboratory derangements just disseminated intravascular coagulation or coagulopathy or DIC? So let's take a moment to just review what the definitions for these various coagulopathies are. So we have sepsis-induced coagulopathy and we have disseminated intravascular coagulopathy, and they essentially exist across a spectrum. But it's important to know that there are specific criterion that would allow you to label someone for having this. So obviously, they're more stringent and more severe for the disseminated intravascular coagulopathy with thrombocytopenia, elevated D-dimer, prolonged prothrombin times, low fibrinogen, and then SOFA scores, which is a marker of illness severity and essentially represents multi-organ dysfunction. And sort of less severe criteria or thresholds for this are seen for the sepsis-induced coagulopathy. So where does the, if you would call it, COVID-19 associated coagulopathy fit in on this spectrum? Is it a disease entity in and of itself, or does it fit along the spectrum, as I mentioned? And I think that remains to be determined because we're not seeing exactly the same patterns as we do with SIC or with DIC, particularly with elevated D-dimers and low fibrinogens, but not necessarily universally prolonged prothrombin time. So Dr. Kirthani already mentioned the significance of myocardial injury. This was a study that we did at Sinai that just looked at the prevalence of myocardial injury as denoted by an elevated troponin. And we saw that over a third of patients had elevated troponins and that it was significantly associated with increased risk of mortality independent of cardiovascular disease history, as you saw in a previous publication for JAMA as well. And how thrombosis potentially leads to myocardial injuries is interesting here because we saw, as you would expect, in tertiles of patients with elevated troponins, that D-dimer also followed this pattern. And so I think it's interesting to see how the two ultimately connect. In this particular study of close to 3,000 patients, independent of elevation in D-dimer, troponin seemed to confer or be associated rather with a higher risk of mortality. And this is in groups. You can see these are patients without elevation in troponin. These are mildly elevated troponins, and these are a little bit more significantly elevated, but overall low levels across the board. So moving into thrombosis, most of what we've seen reported has been in the ICU setting, the first being in Wuhan, where they showed a 25% incidence of venous thromboembolism. 8 of these 20 died. And D-dimer showed elevated over 1.5, showed an 85% sensitivity and close to 89% specificity for detection of VTE. Recognizing that these are all observational data and need to be taken with a grain of salt, but nonetheless high numbers. Subsequently, we saw a report from the Netherlands that reported a 31% incidence of venous or arterial thrombosis, and these were oftentimes despite the use of thromboprophylaxis. Interestingly here, I'd like to point out is that no patient developed DIC. So we had high incidence of, or prevalence rather, of VTE and arterial thrombosis, but not necessarily DIC, going back to the point that I made earlier. Again, another report from France, among 150 ICU patients, there were 64 relevant thrombotic complications. Close to 100 of these had CTAs, where 25% of these patients had PE, so an overall percentage of 17 across the cohort. Interestingly here, these authors noted that of the 57 patients for whom lupus anticoagulant was checked, 50 of them had a positive test result. And this was followed by a publication as a correspondence to the New England Journal. Among 216 patients, 44 or 20% had prolonged APTTs. And of the patients who had prolonged APTT for whom data was available, 91% had a positive lupus anticoagulant. To put it in perspective for historical controls, where 8% had prolonged APTTs, only 26% tested positive for lupus anticoagulant. So the authors here speculate that APTT should not be a barrier to anticoagulation use for fear of bleeding. Of course, these are all limited reports and need to be taken with a grain of salt, as I said, but nonetheless provocative. Subsequently, Mount Sinai published a very small case series in the New England Journal that was alarming, of 5 young patients under the age of 50 who presented with large vessel strokes within a 2-week period. Sadly, 2 of these patients delayed coming to the hospital due to fear of being hospitalized during the COVID pandemic, speaking again to Dr. Sharma's points and Dr. Kirthane's points on not prolonging the need for acute care if needed. So let's talk a little bit about autopsy reports, which I think are really fascinating and very relevant to this topic. There are a number of reports. I'm just going to highlight a few of these. The first come from Hamburg, Germany, where there were 12 autopsies done, 3 female, and there were 7 with major thromboemboli found, 4 with PE and DVT, and 3 with bilateral DVT. Interestingly enough, 6 of the 9 men in this series were found to have venous thrombosis in the prostatic venous plexus, which is seen here. 5 of these patients had D-dimer assessments, all which were elevated, but 7 it was not reported. And 4 patients were on anticoagulation, and 2 of these 4 did have thrombosis. Another report was 11 patients, 11 autopsies in Austria. 10 of these patients were on at least prophylactic anticoagulation, and all of these patients had thrombosis in the subsegmental or segmental pulmonary arteries. Another one just published recently out of New York. This was a 7-case series, 4 of whom were female, 2 died at home, and 5 others were on therapeutic or prophylactic anticoagulation. And these authors showed that platelet-rich thrombi were present in the pulmonary, hepatic, renal, and cardiac microvasculature. And these thrombi seemed to be fresh. They were formed potentially in situ and ante-mortem. And they suggest that profound platelet response in COVID-19 may be responsible, at least in part, for multi-organ failure seen in sick patients. So finally, getting to the billion-dollar question, what is the role of anticoagulation here? Well, one of the earliest reports again came from China, where there was about 450 patients with severe COVID-19, 99 of whom were treated with heparin, mostly low molecular weight heparin and only 5 with unfractionated heparin, and 350 without. And what you can see here is that there was no difference in overall 28-day mortality in those patients treated with heparin versus not. What you can see, however, is age, prothrombin time that was prolonged, platelet count, and D-dimer were associated with increased mortality at 28 days. But when these authors essentially substratified this population, looking at sepsis-induced coagulopathy scores greater than 4, as we went over, treating with heparin seemed to be associated with better outcomes. And the same was true when D-dimers were markedly elevated, 6 or 8 times the upper limit of normal. So our group at Sinai looked at our own cohort of about 2,700 patients and essentially just divided patients for a brief report in JACC on therapeutic anticoagulation versus prophylactic or no anticoagulation. And what you can see is therapeutic anticoagulation treatment was associated with a reduced risk of mortality, approximately 14%. And this effect size seemed to be more pronounced among those patients who were critically ill and mechanically ventilated. I think this report got a lot of press and was sensationalized. I think we have to recognize that these are observational data only and are more so hypothesis generating than anything rather than informing practice. But of course, what you always would wonder about is what about bleeding in these patients? So therapeutic anticoagulation was associated with a 3% risk of bleeding. Interestingly enough, 15 of the 24 bleeding events were patients who had bleeding events after starting anticoagulation. And in the no or prophylactic anticoagulation group, the bleeding rates were 1.9%. So as expected, higher in the therapeutic group, but what we noted, and I think we were surprised about, was that overall rates of bleeding seemed to be low. And not surprisingly, bleeding was more common among ICU patients. We have another subsequent analysis to follow this that's more in depth with a larger cohort and a longer follow-up time, with a more in-depth look at dose and specific agents as well as bleeding that I unfortunately can't share because it's under review, but look forward to hopefully being able to share at a later time. So the role of anticoagulation at present, I think there are more questions than answers. First, do we anticoagulate versus not anticoagulate? I think the data now is more and more pointing us to the fact that we should anticoagulate, but there are many, many questions that remain in terms of how we should do so. Who do we anticoagulate? What dose do we use? What agent do we use? How long do we treat these patients? Is it just before ICU, during ICU, after discharge, and if so, for how long? I think it's critically important to recognize that data from randomized controlled trials are needed to inform clinical management. That's really just very critical. At present, there are 29 clinical trials listed on clinicaltrials.gov. Dr. Kirthani is involved in one of them at Columbia. The NHLBI and the group called the ATTACK investigators are exploring multi-center trials. One is actually underway. The ATTACK trial is underway. And I think these are going to be very informative because COVID has not left us yet. I mean, this is an unfortunate graph that you can see here from the Hopkins coronavirus tracker, where you can see the US is in orange, and I know India is relevant as well, and cases are continuing to rise, unfortunately, despite our maximal effort to get a handle on things. So the results of these trials are going to be critically important to inform future management. So take-home points. Pathogenesis, I think there's a very close tie between thrombosis and inflammation in COVID-19. Laboratory derangements are certainly present, with elevated D-dimers being most notable, but not necessarily the same as DIC. In terms of thrombosis, it's likely common. Autopsy reports corroborate this finding. There are frequent thrombi seen that were not necessarily suspected pre-mortem and despite anticoagulation. And the role of anticoagulation, well, there seems to be a suggestion of benefit, but it's really formally to be determined by randomized controlled trials. And with that, I want to thank you so much for that opportunity to be with you today, and hoping that things improve in India as they have for us in New York. And I would love to take any questions.
So thank you. Thank you very much, Dr. Anu. That was wonderful. All three talks were wonderful, and we had a real good idea of how COVID is affecting the cardiovascular system and patients in general. And this would be a big knowledge and a great knowledge to manage these patients, because now we are in the ascending phase of towards the peak, and probably what you saw 2 months back or 1.5 months back, we are going to be seeing next month. So it will be very helpful for us to actually prepare ourselves